Okay, so these are the two things which they talk about. Okay, so why do we talk about this? I get a child at 1 year, whatever the power comes, I'll put in glass. He doesn't have to wear glasses, but the problem is he's going to grow out of that, and he's going to myopia, which could be a -4, -5, -10, -18. So we've seen patient going to -12, -18 even after the IOLs. So that thing you can't control, but that happens in a very few patients, which are the outliers. So that's why we always take the myopic shift into consideration and make this patient hyperope depending on what you want, with what age. The best rule is Inadi's rule of 7. That means refractive error and the age of the patient. If the age is 6 years, +1. So you need a 1 diopter error. If the patient is 1 year old, you need 6 diopters of glasses in his front of his eyes. And that's a very gross one, but I think in majority of the patient, it works wonderfully well. Okay, so it's the still target you can shoot with the eyes shut also, right? With practice. And we are talking about the moving target because the eye is growing. It's a dynamic eye, it's still growing. So what is going to happen? And let's see about that. Now this is a paper I talked about. So what he talked about was that the normal refractive error at the birth is +4.4 to -0.5. And this was, they've done a huge number of patients. And they realized that if you, okay, all of you know your A constant of your lenses. Even our eyes have a constant. My lens, which is crystal lens, have a constant. And according to Gordon's study, it's 116.4, and which he came out with taking up all the data and putting together and back calculating to calculate the A constant. So we have A constants also. It's not that it's in the lab only, in eyes also have A constant. So this is a study. He's talking to the keratometry, triphasic, and the X length changing accordingly. Now see, this is what he did. He took these kids and 30 to 35 weeks group here, then increasing age, and then he realized that this is what he's getting in all these. Exit length was varying from 15 ±9 keratometry here, and with the SRK lens formula, he could calculate the power and refractive error of these eyes. And I think this is one of the very good studies which every pediatric ophthalmologist has to know, and it's a wonderful study. So what happens when refractive changes in the childhood? So aphakic refraction declines from +21 to +14, 11.4 roughly according to the Scott McCartney. And pseudophakic eyes have a larger myopic shift. That was according to this study. Some people have come out with a calculation on the base of formulas. So wherever the age is, you put a pin. It doesn't work for all patients. Very small cohort of the patient in which the keratometry and exit length are within the limit, you can follow this one. Otherwise, they're more of outliers. So this is what is normal, but most of the outliers are there. So it doesn't work very well. So people have tried all kind of things. So what actually is happening is, in the first 6 months, there's a growth of 0.6 millimeter every month. So 6 into 0.6 becomes 3.6 millimeter. So that means from birth till 6 months, you have got a 3.6 millimeter of the eye which has grown, and which we have seen in our own hands that it happens in all patients. So if you're doing patient of surgery less than 6 months, you have to be very careful. You cannot leave them emmetropic, otherwise you're going to lose everything. So this is where you have to have them higher hyperopic. So I'll come to that later. After 6 months to 18 months, the growth is about a 0.19, about 0.2 millimeter every month, which is not very low, but that's still manageable, right? That much range you can do. But after 2 years, it goes down, and this is a Wilson et al. Study, which I'm quoting. And the other factor which decides the exit length is the age of intervention. IOL versus aphakic, type of lens, rigid versus foldable. There was a study in which they put rigid lens into the sulcus, and they realized that it was actually irritating the ciliary body and causing the exit length to go. So you got to be very careful, and nobody's using a rigid lenses now, so all are foldable. So unilateral versus bilateral. We always think the unilateral eyes are smaller eyes with a small exit length, but there were studies in which they found that these eyes, even after surgery, if they don't use amblyopia treatment, they'll outgrow the other eye also. So they shoot up and go myope. Rehabilitation, if they do properly, if they do the patching well, it works well. IOP, if there's a spike of pressure, those eyes are going to actually go high. We did a study in primary angle closure glaucomas, which Dr. Vinay sent me, and we realized that we have to undercorrect it much more than the normal age matched group. So if you're undercorrecting by say 10%, here we're doing about 20 to 30%. It was so high, and it was variable again, because the pressure spikes, the cornea goes so thin, it actually shoots up. And the genetics. Now that's the factor which, if you're sitting in your clinic, like you're sitting in Mayo, your patient growth is different than what we're seeing, say Monga is seeing at center of a site, or maybe Nayan is seeing in Rajasthan. So you have to follow those patients with the same group of ethnicity, and you realize that everything is different. We are all the same, But there are lots of things which are actually in your DNA. You can't change your DNAs, can you? So age of intervention, he said, is what is, she talked about, it's good. I think we agree with that one. Now, effect of the aphakia or pseudophakia or excellent growth, there are lots of paper on that. And actually some papers say that there's no difference. Right? And the other one says that excellent retards, and some say it grows faster than what you expect. So these are all studies which you can see. Now, that's a chart which talks about the Lambert study says there's a retardation, whereas the other one says that no difference, and increases. Now, all the newer studies which are coming, because I think they're able to measure the excellent biometries much better. All the newer studies, 2009, 2004 says that there's an increase in these eyes, and you got to be a little careful about that. Okay. So I think Wilson Group sent in a questionnaire to the adult cataracts and the pediatric cataract surgeons to check out what is their take on the IOL power calculation. So what this found out was this one. At the 6 months of age, so first is the ACRS group, the other one is the APOS group. So he wanted to check out what is a pediatric surgeon who's doing it and what is the adult surgeon's perspective of a pediatric cataract. So what you realize is that the pediatric ones are doing more undercorrection, more hyperopia as compared to the adults, because they're used to the adults. So when they go undercorrection more than say 5%, they start feeling jittery and they don't know what they're doing. But these eyes are dynamic, they're growing, they're going to change, they're gonna come back into the zone where you want them to be sooner or later. So now coming to the lens, I think PMMA nobody is using now, we can actually stop it. Unilateral eyes, I think that's the biggest bed bug, and you have to tell the parents that we are trying our best to give them, but it's your input which is more important. Glasses, frequent change of glasses, occlusion treatment, and frequent follow-ups. And if there's an ESO deviation, then you have to do the surgeries also in these patients. Okay. So let's quote about this. When we started these pediatric cataracts about 30 years back, I think these were the people who were doing more work, the Hans and Prost. Then we started copying this one and following this one. And we realized that we were burning our fingers because most of the hyperopias were actually not regressing. They were doing very high amounts. For example, less than 2 years, they're doing 20%, and 2 to 8 years were 10%, which is pretty high in these patients. And and that's the same thing which Prost has come across. So what we do is we close to what NID's group says, which is good. So what we did in the RP center, we did a thesis which finished about 3 years back, and we're still following the patient. We picked up these cohort in which we had less than 6 months age, 6 months to 1 year, 1 year to 2 years, 2 years to 5 years, and more than 5 years. So in each group we had about a fair number of patients in these one, and we did the excellent keratometry, operated this patient, and then followed all these patients for the last 2 to 3 years. And this was the IOL power which we got in most of the patients, less than 6 months, actually had 25 plus minus 2.5 with a 20% undercorrection. And whereas the bigger one had 2% undercorrection, right? So that's a difference. That much is the shift. And when we did the refraction post-op, so you see we are from 0.6 plus to 2.4 to 1.1 to 0.3. So even if you have an error of plus minus 2 diopter in these kids, you should be very happy and pat your back, because even achieving that one is almost impossible, right? So what we do in the center, RP center, is if it's more than 5 years, you can go first hyperope, otherwise you can ignore that also and just go for the emmetropic. These eyes not going to grow too much, and if they wear the glasses, the growth is not going to be too much. So you just don't do it, do a emmetropic power, whatever you get, just give it. At 5 years, you do 2%, and at 2 years, you give 5%. Simple. Between 1 to 2 years, 10% is absolutely fine. And when I'm talking about this, we actually measure both the eyes. In case we think one eye is not behaving on the excellent well, then if you're doing the smaller eye first, we'll consider that excellent also to be compensated in this eye. 6 months to 1 year is very good. Till 15%, there's no problem at all. We've been doing it for last at least more than 15, 20 years now. We haven't burned our fingers much. The problem is when you have 3 months to 6 months and less than 3 months. If the less than 3 months, and if you're not comfortable, please, you can leave the patient bilateral aphakics. It's a fantastic surgery, bilateral aphakic with glasses. Plus, the only thing you should add on is when you do the surgeries, please, for God's sake, leave some rim in the periphery. Don't eat up the thing like the VR guys do. Whenever we get the patient which are lensectomy done by the VR guys, somewhat hurts the ego to leave any capsule of things in the periphery. They eat up everything. So you have to go to the iris to do some surgery. Otherwise, if you have your rim around, even if you have a 4.5 millimeter rim in the periphery, that's perfect for a 3-piece lens in the sulcus, which I think he told you about the surgery. So now we got 3 to 6 months also under our control. We are managing these patients pretty well. But let's just 3 months, we're still doing it because in our scenario, the patient are not going to use contact lenses. Even the FAK glasses, they'll buy once in a village. If it breaks, they might get second time. If it breaks again, they can't afford, they can't go anywhere. So they don't have money to eat. So what do? So that's why we are a little aggressive on the IOL. It's just basically we want them to actually see. So finally, we talk about the ELPs, effective lens position for the adult to make your power calculation accurate. I think it doesn't hold water here because you don't know which lens you're putting where. You might be putting lens with the capture, it might change the power. So using of the glasses, contact lenses, if the patient can afford, should do it. Post-operative refraction and axial data, I think is a must for everybody who's doing the surgery. If you can follow a patient for 4-5 years, you know where you're heading and what you're doing. If you've done 2 eyes in which one you did a vitrectomy properly, another eye didn't do a good vitrectomy, the eye is excellent. In 5 years is going to be different. Take it from me. Because whenever we burned the fingers, we went back and saw the data, which are the eyes which are same surgery done. What was the problem? Vitrectomy didn't work. So please look into the data. If there's some problem there only, if the same in gap of 3 days you're doing the same procedure, results should be the same. Okay, I think ideal size is to put in the bag. If not, the sulcus works well. I think, all right, so I'll just conclude now. So this is what I'm trying to shoot. See, this guy is trying to shoot emetropia, but he misses out, right? Now he goes and checks up and checks our, he attends our symposia also. Now he's become wiser. He knows the eye is growing. I don't have to shoot at it. I have to shoot in front of it so it comes and hits a target. So now I think this guy has become wiser and he shoots and bullseye. So bullseye doesn't mean a 0 refractive error. A plus -2, you're good. If it's -2, the chances are that -2 might increase further. If it's +2, you're still happy about it. And you should be content with that. Just keep wearing glasses and compensate for refractive errors. And thank you very much for your